So, think of the human pelvis like a really complex suspension bridge. You got the bones acting as these heavy stone towers.
Right, and the muscles are basically the cables.
Exactly, yeah. The pelvic floor muscles and the ligaments, the tension cable standing between them. And for that bridge to carry the daily load of just, walking around, everything needs to be perfectly balanced.
Absolutely.
But if just one cable gets pulled tighter than the others, the whole bridge kind of shifts on a diagonal.
Orbs.
Right. And suddenly, all the forces of traffic are distributed unevenly, which puts massive, highly localized strain on very specific joints and wires.
And when that twisted bridge is forced to handle dynamic, repetitive impact, like we're going to talk about today, that uneven tension doesn't just cause a little sway, it causes a profound, highly localized mechanical failure in very specific pockets of the structure.
Which brings us to the actual topic. So welcome to your custom-tailored deep dive. We're exploring a topic for you today that is incredibly common, yet so frequently misunderstood or just completely brushed off.
Yeah, totally dismissed.
We're looking into the biomechanics of painful sex. Specifically, how structural asymmetry in your pelvic girdle, that suspension bridge we just mentioned, alters the mechanical vectors of deep thrusting and creates this highly localized pocket pain.
And we are definitely not just guessing here.
No, we are not. We've spent time poring over this massive stack of urogynecology surgical case reports, advanced biomechanical data, high-density nerve mapping, and clinical physical therapy guidelines, just to shortcut your journey to being perfectly informed on all this.
Because the overarching goal here is to really shift the paradigm. We want to show you that deep pelvic pain during intimacy is rarely, just in your head.
Right.
And it's almost never just a simple hormonal issue, like a lack of estrogen. It is a highly treatable puzzle of physics and angles and anatomical tension.
Okay, so let's unpack this from the ground up. Because when people hear painful sex, I think they usually think of menopause or maybe vaginal dryness or superficial pain right at the entry point.
Yeah, exactly.
But the data we're looking at describes an entirely different mechanism. This is literally about blunt force mechanics.
It's pure physics.
Right. So before we even talk about the pelvis being asymmetrical, what is physically happening internally during deep intercourse that causes this very specific type of pain?
Well, we have to look at the vectors of movement. The clinical term that shows up in all the urogynecology literature is collision dyspareunia.
Collision. That's a really intense word for intimacy.
It is, but it's accurate. Patients don't describe this as a burning or tearing sensation at the surface. They describe it as a sharp, deep, aching pain with penetration. It is quite literally the physical sensation of hitting a roadblock internally.
So the thrusting is actually colliding with an internal structure. What exactly is getting hit?
So during deep thrusting, depending on the angles involved, the penis can repetitively impact the cervix, which is, the lower part of the uterus that extends down into the vaginal canal.
Okay, yeah.
It can even transfer force to the uterine fundus, which is the very top of the uterus. And this collision becomes a major source of pain if a woman's anatomical structure has somehow shifted.
I want to make sure I'm picturing this right for everyone listening. If the uterus shifts, it literally changes the physical runway. Right.
It completely changes the depth and the angle of the runway. Take a retroverted uterus, for example.
Which means it's tilted backward.
Right. The uterus naturally tilts backward toward the spine instead of tipping forward over the bladder. Or consider uterine prolapse, where the supporting ligaments have weakened, and that allows the cervix to drop much lower into the vaginal canal.
So it's hanging lower down.
Exactly. In both of those scenarios, the collision vector is suddenly much shorter. So even a totally normal depth of penetration suddenly results in repetitive, blunt force impact against the cervix.
Wow. That sounds incredibly painful. But the medical reports go even deeper than just the cervix, don't they? I was reading about these specific spaces in the pelvis that kind of get caught in the crossfire.
Yeah, the anatomy gets highly granular here. The surgical literature introduces us to structures known as deep retractive pockets.
The deep retractive pockets.
Right. So if you picture the lower part of the uterus, it's tethered to the sacrum, the base of your spine, by the uterosacral ligaments. And the spaces around these ligaments form natural anatomical pockets deep inside the pelvic cavity.
Okay, I can visualize that.
Yeah.
But why are those pockets so sensitive to collisions?
Well, because they aren't always empty or pliable. These deep retractive pockets frequently house endometriosis implants, which are highly inflammatory.
Oh, wow.
Or they might be filled with dense, rigid scar tissue from like previous pelvic infections or maybe surgeries. So when the mechanical vectors of deep thrusting stretch those ligaments or physically bump into those specific pockets, it pulls on that inflamed tissue.
Which would hurt a lot.
It creates a very sharp, breath-catching, localized pain.
It makes complete sense when you visualize it as a purely physical collision. But, doesn't the body have a natural defense mechanism against this?
Yeah.
I'm looking at the notes from the clinical physical therapy guidelines, and they spend a ton of time discussing the physiological role of arousal.
Yeah, they do.
It seems like the body's actually designed to prevent this exact collision.
It is. The physiology of arousal is just a brilliant mechanical adaptation. When a woman becomes highly aroused, a phenomenon called tenting occurs.
Tenting.
Yes, the vaginal canal actually lengthens and the upper portion widens. And at the exact same time, the uterus actively lifts up and out of the lower pelvis.
It's essentially pulling the cervix up and completely out of the way of the collision vector. Like it creates more physical space.
It alters the internal dimensions entirely, yeah. But if penetration happens before full arousal, or if, arousal drops off for whatever reason, that tenting doesn't occur. The uterus and cervix sit lower, the canal stays shorter, and it becomes vastly easier to bump those sensitive, retractive pockets.
All right, so we've established the what. Collision dyspareunia is about mechanical vectors either hitting the cervix or stretching these deep, inflamed, retractive pockets.
Right.
But here is the massive question that really sparked this whole deep dive for you listening. Why does this pain so often happen in just one highly localized spot?
Yes.
Like, why does a patient go to the doctor and say, it always hurts in this one pinpoint pocket on my left side, but my right side feels totally fine?
To answer that, we really have to return to your suspension bridge analogy. We tend to think of the human skeleton as perfectly mirrored. But biomechanical studies reveal that the human pelvic floor is almost never perfectly symmetrical.
I mean, nobody's face is perfectly symmetrical, so it makes sense that our hips wouldn't be either. But how common is this unevenness? Like, really?
It's nearly universal. Researchers tracking pelvic asymmetry, or PA, note that an asymmetry index below 1 degree is considered physiological, meaning it's just the natural baseline. But measurable, significant pelvic asymmetry is staggering in its prevalence. One biomechanical study actually found that 95% of healthy, active athletes had measurable pelvic asymmetry.
Wait, hold on. Let me pause you there, because that feels like a massive contradiction. If 95% of healthy, high-performing athletes have a crooked pelvis, isn't that just a normal human quirk?
Well,
Why would we be labeling it as the root cause of severe pain during intercourse?
It's a really vital distinction to make. Having asymmetry is a normal, harmless human quirk. The biomechanical data points out that our bodies are actually designed to handle asymmetry dynamically.
So moving with it.
Right. The problem is not having an asymmetrical pelvis. The problem is getting stuck in it. When your pelvic girdle gets locked into one specific twisted pattern and loses the ability to shift back to neutral, you lose adaptability.
Oh, I see.
And when you force movement, like deep thrusting into a structure that can no longer adapt, that's when tissue gets damaged and the pain starts.
And there is a very specific, totally predictable way that human beings get stuck, isn't there?
Yep.
The literature calls it the left AIC pattern.
Yes, the left anterior-interior chain pattern. It is a fascinating concept in biomechanics. A chain simply refers to a linked series of muscles and joints that fire together to create movement, kind of like a pulley system.
Okay.
And the left AIC connects the diaphragm down through the abdominal wall and right into the left hip. But the reason this specific chain gets disrupted all the time comes down to the macroscopic layout of human organs.
This blew my mind when I read it. We think of our insides as being balanced, but they aren't at all.
Not remotely. Your organs are substantially denser on the right side of your body. Your liver is a massive, heavy organ sitting on your right side.
Right.
And to accommodate that, the right side of your diaphragm is physically larger and thicker, which gives it a mechanical advantage over the left side.
Because it literally has to stretch over that giant, dense liver just to function.
Exactly. Because of this right-sided density and biological bias, human beings naturally feel more neurologically and physically stable loading their body weight onto their right leg.
Wow.
We spend significantly more time standing on, shifting onto, and pushing off our right side.
So, going back to my analogy, it's like walking for miles with one shoe that has a slightly thicker sole than the other.
Yes.
You might not notice it at first because your body naturally adapts to the unevenness, but eventually, because you're constantly leaning into that right side, the right hip socket and all the muscles around it end up taking all the strain.
That's a perfect visualization. When you constantly load the right leg, it creates an internal rotation on the right side of the pelvis. The right hip bone literally rotates forward and in.
Ow.
And this physical rotation twists the suspension bridge. It chronically shortens and tightens the right anterior or front quadrant of the pelvic floor. And as a counterweight, it pulls the left posterior or back quadrant incredibly tight.
Okay, so the bridge is twisting on a diagonal axis. The front right is locked tight, and the back left is being dragged tight to compensate for it.
Exactly.
And because these muscles are literally anchored to the pelvic bones, this chronic tension alters the shape of the pelvic cavity itself.
It warps the cylinder entirely. So when you introduce the dynamic, repetitive, mechanical vectors of intercourse into that environment, you aren't thrusting into a flexible, symmetrical space.
Right, it's totally rigid.
You are thrusting into a twisted chamber where certain ligament pockets are already pulled completely taut. A collision that might normally be totally harmless suddenly hits a structure that has zero give.
And here's where it gets incredibly intense for you listening. Because this twisted asymmetry isn't just making the pelvic muscles sore. It's actually trapping and crushing the body's electrical wiring. We're moving from just muscle mechanics into severe nerve entrapment here.
Yeah, to figure out how a twisted pelvis translates into that severe localized pocket pain, researchers started mapping the electrical wiring of the pelvic floor in high definition.
Which is so cool.
It is. This brings us to the high-density surface EMG studies. Researchers use algorithms to map the exact electrical firing of pelvic motor units.
The results they found were just wild. The algorithm detected that in patients with chronic pelvic pain, there were significantly more motor units firing on the right side of the pelvic floor.
Yes.
The rest in muscle activity was objectively higher on the right, which tracks perfectly with what you just explained about humans constantly loading their right leg and locking down that right front quadrant.
But then the researchers hit this massive paradox. Even though the right side was working harder and firing way more electricity, when doctors physically palpated the patients when they pressed on the internal tissue to check for pain, the extreme tenderness was actually located on the left side.
I struggled to wrap my head around this at first. The right side is doing all the heavy lifting and firing constantly, but the left side is the one screaming in pain when you touch it. Like, why?
It all comes back to the twisted suspension bridge. The right side has higher electrical activity because it is clamped down. It's contracted, shortened, and stubbornly holding that twist.
Okay.
But because it's pulling so hard, the muscles and ligaments on the left side are being constantly dragged and overstretched across the pelvic cavity.
Oh, like a rubber band being pulled to its absolute snapping point.
Exactly. Muscle tissue that is chronically overstretched becomes highly inflamed, sensitized, and incredibly painful to the touch.
Right.
The right side is just tightly flexed, but the left side is hanging on for dear life. That's why chronic pelvic pain exerts vastly different influences on each side. The asymmetry literally changes the neurological behavior of the tissue.
And when we talk about pelvic neurology and pain, I mean, the ultimate culprit is almost always the pudendal nerve, right?
Pudendal neuralgia is one of the most notoriously painful conditions a person can ever experience. The pudendal nerve is the main nerve supplying the genitals and pelvic floor.
It's the main wire.
Yeah. And it travels down through the pelvis. And to get to its destination, it has to pass through a very narrow gateway between two major ligaments, the sacrospinous and sacrotuberous ligaments.
So these are basically the main tension cables holding our twisted bridge together.
Now imagine your pelvis gets stuck in that left AIC twist. The right side rotates, the left side drags, and the tension on those two major ligaments fundamentally changes. As the medical literature describes it, when these ligaments are pulled taut by an asymmetrical twist, they cross over each other and act like a lobster claw.
Oh, that is a horrifying image. A lobster claw.
It is mechanically devastating. That ligamentous lobster claw pinches down directly onto the pudendal nerve as it tries to pass through.
Oh, ouch.
So the uneven tension from the asymmetry isn't just making the muscle sore, it is pulling the structural cables tight like a vice grip around the main nerve of the pelvis.
And then during intercourse, every single deep thrust is pushing and pulling against a structure that is already actively crushing a nerve. No wonder patients describe it as a sharp pinpoint pain.
And in severe cases, the anatomy gets even more entangled. There is this surgical case report in our stack regarding a patient with debilitating localized pelvic pain. When the surgical team went in to decompress the nerve, they found something highly unusual about how her anatomy had adapted to all this tension.
What did they find? Because normally the nerve just passes between the ligaments, right?
Normally, yes, it just goes between them. But in this case, the chronic tension was so severe that the pudendal nerve had actually penetrated the deep layer of the sacrotuberous ligament.
What?
Yeah, it had threaded itself directly through the dense ligament tissue. And because that ligament was pulled taut by the pelvic asymmetry, it was tightly constricting the nerve right at the penetration site. Literally like a wire pulled tight through a knot.
That's completely structural.
Yeah.
You can't meditate or deep breathe your way out of a nerve threaded through a clamped ligament?
You certainly can't. And this constriction caused extreme perineural venous engorgement.
Okay, what did that mean?
Because the nerve was being choked, the tiny veins surrounding the nerve couldn't drain. The blood flow was cut off, causing massive swelling.
Oh, wow.
The surgical team literally had to perform a layer-by-layer release, delicately slicing the ligament away to free the nerve and allow those engorged veins to finally drain.
That paints such a vivid, undeniable picture of what is actually happening.
Yeah.
You've got these deep retractive pockets hiding inflamed tissue. You've got a twisted pelvic floor caused by the sheer weight of our own organs loading our right leg.
Yep.
And you have nerves getting pinched in a lobster claw, or just literally choked inside the ligaments themselves. It makes total sense why deep thrusting causes such sharp, localized pocket pain.
Which brings us to the most crucial part of this deep dive for the listener. The ultimate question, what do you actually do with this information? Now that we know deep pocket pain is a structural issue of uneven vectors and pinched nerves, how do we fix the bridge?
Right. So based on the clinical physical therapy guidelines, there are two distinct ways to tackle this. First, you have to manage the mechanics during the act of intimacy itself. And second, you have to fix the twisted bridge outside the bedroom. Let's start with what you can do in the moment.
The most immediate mechanical solution is controlling the depth and the angle of the penetrating vectors. If the pain is caused by hitting the cervix or stretching the uterosacral ligaments near the back of the pelvis, you simply need to redirect the traffic.
You change the angle of the runway.
Exactly. For instance, in the missionary position, the angle of the woman's legs completely changes the tilt of the pelvis. If she lowers her legs flat to the bed rather than having her knees pulled up toward her chest, it physically tilts the bottom of the pelvis forward.
So instead of the thrusting vector aiming deep toward the back where those sensitive pockets in the cervix are, it angles the penetration upward toward the pubic bone at the front.
You are quite literally changing the internal trajectory to completely bypass the collision zone.
That's so simple but effective.
It is. The clinical guidelines also suggest using a physical buffer to limit depth entirely. A very simple, accessible method is for a partner to form an O shape with their thumb and forefinger at the base of the penis. This acts as a physical stop, preventing the penetration from reaching the full depth where that collision occurs.
Oh, that makes sense.
And there are also specialized soft silicone rings designed for this exact buffering purpose.
So during sex, it's all about managing the physical space and changing the angles. But what about the underlying issue? How do we fix the asymmetry itself and untwist the bridge? I feel like we're constantly bombarded with messaging that the answer to all pelvic health issues is strengthening.
Oh, absolutely.
Do your endless Kegels at the stoplight, squeeze the muscles, build the core.
If your pain is caused by an asymmetrical hypertonic, meaning overly tight pelvic floor, doing Kegels is the absolute worst thing you can do.
The worst thing.
Yes. If you have a left AIC pattern where your right front quadrant is already clamped down and your left side is stretched to the limit, actively squeezing those muscles just adds more tension to the lobster claw.
You're just tightening the vice grip on the nerve, so you actually need to do the exact opposite.
The primary focus of physiotherapy for this specific type of dyspareunia is called down training. The goal is to consciously relax, lengthen, and drop the muscles to restore symmetrical balance.
And the physical therapy literature mentions a technique called reverse Kegels, which honestly sounds like an oxymoron to me. What does a reverse Kegel actually feel like?
A reverse Kegel is essentially a conscious pelvic drop. Instead of pulling up and in, you focus on relaxation to allow the pelvic floor to open and widen.
Okay.
It is the exact physical sensation of release that happens right before you begin to urinate or have a bowel movement, but you do it without actually pushing or bearing down. You just let the floor drop. Practicing this reduces the baseline resting tone of the muscles.
So you are intentionally slackening the overly tight cables on the suspension bridge, so the twisted pelvis can finally settle back into a neutral, balanced alignment.
Exactly. And we should note that in some cases, the asymmetry isn't just caused by tight muscles pulling the bones out of place. Sometimes it's caused by the joints themselves being too loose.
Oh, interesting.
The pelvic guidelines note that asymmetrical laxity in the sacroiliac joints, where the spine meets the pelvis, can disrupt the whole system. If one joint is loose, the muscles on the other side freak out and clamp down to try and hold you together.
So how do you fix a loose joint if you're supposed to be relaxing the muscles?
The guidelines suggest a very simple, non-invasive mechanical support, a pelvic torque belt. Wearing a specialized belt snugly around the pelvic girdle generates a self-bracing effect.
Like an external bridge support.
Exactly. It provides external physical compression that stabilizes the loose joints for you. Once the joints feel secure, your nervous system stops panicking, the muscles stop overcompensating, and the pelvic floor can finally relax.
It is endlessly fascinating how purely structural these solutions are. Change the angle of your legs to bypass the pockets. Use a physical ring to limit the collision depth. Actively drop and relax the muscles instead of squeezing them. Or literally wear an external brace to hold the heavy bones steady.
The solutions are structural because the root of the problem is structural. It is a mechanical mismatch, not an emotional barrier.
So, to really bring this all together for you listening, we started by looking at how our natural biological tendency to bear weight on our right leg, driven by the sheer density of our liver and our right diaphragm, can create a twist in our pelvis over time.
That asymmetrical twist chronically shortens muscles on a diagonal axis. It traps major nerves and ligamentous lobster claws, and it aggressively tightens the deep, retractive pockets hiding in the pelvic cavity.
And when you introduce the dynamic mechanics of deep intercourse into that twisted, cramped space, you inevitably get collision pain. The thrusting vectors hit the cervix. They pull on those inflamed uterosacral pockets, and they tug on those trapped nerves. And the result is that severe, highly localized pocket pain.
But once you understand the mechanical why behind the pain, you take the power back. You
Yeah.
can change the angles of intimacy to avoid the collision zones, and you can use down training and support belts to untwist the pelvis entirely.
I think the most important takeaway for you today is this. If you or your partner experience this deep, sharp pain during intimacy, it is not a psychological failing.
Yeah.
It is not a sign that you are broken. And it doesn't mean you've somehow lost your romantic connection. It is quite literally a structural puzzle of biological angles and tissue tension that is just waiting to be balanced.
And when you really zoom out and look at the biomechanics of it all, it raises a profound, almost philosophical question about how our bodies dictate our lives.
Oh, lay it on us.
We just mapped out how our natural organ asymmetry, the simple biological fact of having a slightly larger right diaphragm and denser organs on the right side of our bodies, can completely dictate the tilt of our pelvis.
Right.
And we know that pelvic tilt can cause severe nerve pain during intercourse. It really makes you wonder, how much of our broader psychological relationship with physical intimacy, our confidence in the bedroom, our deep anxieties about pain and connection, are secretly being driven by the microscopic gravitational pull of our own internal organs.
That is absolutely wild to think about. Our emotional and psychological connection to sex, secretly dictated by the sheer weight of our liver pulling our suspension bridge out of alignment. We will definitely leave you to ponder that one.
Thank you for taking this deep dive with us.